And the question is MRI fusion biopsy the new gold standard of diagnosis? I'll be arguing the pro. My disclosures. So I'm always asked this question: what would you do if it was you, Doc? And I want you to keep that in mind as we keep going through this data. So in the past, Dr. Donahue, maybe you could shed some light on this, but prostate biopsy was performed under digital guidance together with systematic biopsy. Well, thankfully, with the introduction of the ultrasound, it saved the urologist's finger, but tumors were not seen with conventional ultrasound. Lack of visualization with the stage migration that we've experienced resulted in this widespread adoption of the blind biopsy, which euphemistically has been referred to now as the systematic biopsy. So this is a very interesting fact. Prostate cancer is the only cancer that is diagnosed mainly by systematic organ sampling rather than visual or image guidance. It's crazy. David McCullough, one of my partners at Wake Forest, popularized the original sextant systematic biopsy, which morphed into the 5-region biopsy, which then became the 12-core, and now the perineal the mapping biopsy, the saturation biopsy. This is what it looked like in the day. Compared to, so the PROMIS trial. This is Lancet 2017, comparing a templated biopsy, truss biopsy, with MRI-guided biopsy. Men with PSAs, up to 15 with no previous biopsy, underwent MRI with a 1.5 Tesla MRI, which many would argue is inferior technology today. Clinically significant cancer was defined as Gleason 4+3 or above. Maximum core length of 6 millimeters or longer. 580 patients were included in the analysis. 408, or 71% of the 576 men had cancer, with 40% being clinically significant. So the MRI-guided biopsy was way more sensitive at 93% compared to the regular truss biopsy at 48%, but less specific at 41 versus 96. 44 of these 740 patients had a serious adverse event, 8 of which had sepsis. Here's the breakdown of the data. So 576 patients underwent MRI, 418 had a significant MRI finding concerning for cancer, 158 did not. So you can see here that 213 of the 418 did in fact have cancer, 109 of the MRI PIRADS 5 versus 26 of the MRI PIRADS 5 that had no cancer. Again, this is on mapping biopsy. So based on this data, they claim a sensitivity of 93%, positive predictive value of 51%, specificity of 41%, and importantly an NPV of 89%. So using this method, together with mapping biopsies, 27% of patients would have avoided a primary biopsy, 5% fewer clinically insignificant cancers would have been diagnosed, and importantly, 18% more cases of clinically significant disease would have been detected. Now, what about after radical prostatectomy? So Jim Hu and company from Cornell looked at the concordance between biopsy and radical prostatectomy specimens. They did a meta-analysis looking at 10 studies involving 1,215 men who underwent targeted biopsy, regular prostate biopsy, as well as radical prostatectomy. And the targeted biopsy group was upgraded 23% of the time, whereas the systematic or regular biopsy upgraded 43% at radical prostatectomy. Crazy. The odds of upgrading at radical prostatectomy after a systematic biopsy as opposed to MRI-guided biopsy was 1.75. This is interesting, Dave. For biopsy-naive men, the risk of upgrading was 2.47. But following a negative biopsy, that goes up to 4.23. So it makes a big difference. So the PRECISION trial. I'm sure you all know it. It's the New England Journal of Medicine trial, multi-center randomized non-inferiority trial men with a clinical suspicion of prostate cancer who had not undergone biopsy previously. So again, these were biopsy-naive patients who underwent an MRI with or without targeted biopsy versus standard truss. Men with normal MRIs were not offered biopsy, which I think is a weakness of this particular study. 500 men were randomized. 71 of the 252 in the MRI group, or 28%, were not biopsied. So they had normal MRIs. We don't know what they had. Clinically significant cancer, though, was detected in 38% of the MRI group as opposed to 26% of the standard group. And fewer men in the MRI-targeted biopsy group received a diagnosis of clinically insignificant cancer, so 13% reduction there. So then, in 1975, with that finger-guided biopsy systematically going through, this is what it looked like. Now, today in 2020, an augmented reality situation, which is getting further augmented by technologies like the exact ultrasound, which we used together, David, just the other day, and enhanced our vision of that nodule in the left base, where we could really see it on ultrasound. It was enhanced with MRI, and we made a diagnosis which possibly we would have missed otherwise. So I pose to you, what would you rather do if it were you? Can we really justify not offering this technology to patients? I think not. When I look at them, my patients in the eye, and they ask me, what would you do? I have to say, the MRI enhances my picture. I would proceed with an MRI-guided biopsy followed by a systematic biopsy. That's what I would do. It's up to you now to convince people otherwise. Thank you.